Hello, everyone, and welcome to our July 2025 Q&A. We're super excited today for the number of folks that have signed up in the dead of summertime. And when I was doing these slides, I was honestly thinking about the dog days of summer. And Cindy mentioned her former pet, Max, who was the cool little beagle. And so this picture came to mind, and I hope that everyone on here is being able to take some time and refresh and enjoy the summer with their kids and with grandkids and all that kind of stuff. So we just appreciate you being here, or even if you're listening to the recording, we appreciate you being here. Cindy, are you out there?
I'm out there. I just think it's always been interesting to provide services in the home in those dog days of summer. I remember well going into the older adult's home who insisted that it was cooler if we kept all the lights off, the shades pulled, no windows open, and no air conditioning. Meanwhile, they're dressed in long sleeves and long pants. Um, Hoping that we could get through a therapy session without me wanting to pass away. So I have great empathy for the folks that are going out to the home this time of year and trying to deal with some of the between that and the storms and all that stuff going on. It just adds a whole other layer to delivery of care in the home setting.
And I also want to just give a huge shout out to women of a certain age that are having to attend these homes and go in to these different places. Sometimes in my past visiting life as a clinician, it would be a 3 or 4 shirt day, especially down here in Florida. And I got really slick at how I would just kind of bump into the air conditioner and turn it down while I was in the house. But it's a challenge for sure to stay hygienic on your own, but also to take some of the climate settings that your patients choose for sure. I wanted to ask for everybody's patience as we have someone lurking in the background today. Scott Curry is on with us, and he's our contract coordinator. And I'm probably butchering his title, and want to make sure that as a member of our leadership team, as he starts to take over some of the technical processes of this meeting, that we may have a glitch here and there today, so bear with us. But we are recording, so that's a good thing. Those of you that have been attending these for a while will remember. I think it was March of 23 that we royal I forgot to hit the record button. Cindy, do you remember that wonderful day?
I remember, and that's part of the decision we made to bring Scott in to help us work the platform even better. We know that this is a less formal structure to these calls, but we want to make sure that some of the oops, did we push the wrong button thing or captioning weird stuff, we want to try to minimize that. So Scott's role today is to kind of see how we've been set up. And then, if you guys have some super secret, awesome thing you figured out Zoom can do that you think would help here, please go ahead and put that in the chat box.
So, are you ready to get started, Cindy?
Yes, I am.
Okay, here we go. The first question was an interesting one. For once, the first question we got wasn't about Oasis. Hallelujah, I think. But I'm sure we're going to get into some good Oasis chatter later. Can you please talk about the expectations for home care related to documents/orders for bed rails?
Fire away, Sherry.
Cindy and I discussed this one ahead of time, and this is definitely in my wheelhouse. Want to make sure that everyone understands that this is the same conversation we would have surrounding any DME, not just durable medical equipment, not just bed rails, but also a bedside commode, a walker, all the ones that are covered by Medicare A and by as part of as a non-bundled charge. So you have to do all the same things. You have to capture the demographics of the patient, obviously, but you want to speak to the physical limitations and the safety aspects of the need for bed rails. And I'm going to take it one step further. Cindy, and I told you I was going to do this. If I have to order bed rails for my patient to keep them safely in their bed, be it their personal bed or a hospital bed, we need to start looking at the status of that case. And we need to start looking at, is this the right place for that care to be occurring? Oftentimes, we're really hesitant to go towards hospice or towards palliative care, but there's things that we need to consider around ordering this upper level, a Hoyer lift, bed rails, a motorized, I say a motorized chair, but that's so popular that probably doesn't get included in that conversation. But those things that are going to keep a bed-bound patient safe, then we need to start having real discussions about that next place of care. Cindy, do you have any thoughts on that?
Well, I think, beyond the technicalities of ordering bed rails, I think there's the flip side of that is sometimes it's the difficult conversation with the patient and the caregiver of why you are recommending those or why you think they're necessary. Sometimes it's really just an issue of if they had something more solid to grab onto, they would be able to roll and position themselves much better and be able to participate in some of the self-care activities better. In other cases, it really is about concerns of them falling out of the bed. And does it need to be a partial rail or a long rail? And some families and patients can be resistant to that. They might see it as, okay, this is really saying that the patient is getting progressively worse. But in reality, we are trying to maximize their safety. I don't think there's enough conversation about some of that DME with respect to is it possible that adding those types of things can really make a difference in that safety element. And in some cases, give them a bit more security in being able to move around in that bed without worries of falling out or not really having anything to grab onto. Or my favorite was, grab the thing next to the bed that actually has wheels and try to pull on that or pull on a lamp pole or things that we go, oh, please don't do that. That's really not a good idea.
Exactly. And there are a lot of options out there for folks to decide, what kind of railing is going to be the best. And honestly, the folks that provide the durable medical equipment, they're under so much scrutiny that they will absolutely tell you exactly what they need to get these patients what they need and what can be paid for. So I would be open to allowing them to guide you to that documentation. And when it feels a little hinky, like if you have to put a different diagnosis or if you have to somehow pump up your documentation in a non-organic way in order to get that item, you may have to consider why that item at that time, and are you the correct setting for that folks if their impairments are at that level. So it's always, we always are supposed to start discharge planning on admission, right? That's a concept that's been around in home health forever. This is one of those maybe prompts to say, now's the time really to start talking about discharge or transfer to another level of care. So it's food for thought, but I thought that question was really timely considering some of the changes also that are in the final rule regarding DME and how it may be going back to competitive bidding, which is a whole other conversation. Now, Cindy, did you have anything else before we close out that question?
Well, I think the other piece of DME is advocacy in terms of, if it needs to be a full rail and they're insisting in only sending out a half rail, or other pieces of equipment, they need wheels for the walker, but they're only giving you a standard. Being able to present the right documentation, the supportive orders, the rationale to get the appropriate piece sometimes requires a bit of back and forth to make sure that all the justification is in place and you don't end up getting a piece that doesn't really work for the patient. Because I think, Sherry, you've probably been in the home as well where there's DME basically propped in the corner or left in the other room because it was delivered. It's not right. They don't know what to do with it. So it just kind of sits there, which doesn't really make sense.
Exactly. Do you guys have any oh shoot, I was going to ask a question open-ended to the 50 or so people that are on here. Probably not a great idea. Sorry about that. But if you join our Oasis Club, we do open the mics and we do open conversations during that. So if you have any further questions about that and how it relates to the Oasis and how you document things and impairments and such, please consider joining our club. Okay, you ready for the next one?
Yep.
Okay, I told you it wasn't going to be too far down the road here. M0090, date assessment completed is the last date that information used to complete the comprehensive assessment and determine OASIS coding was gathered by the assessing committee and documentation of the specific information response was completed. First question, if clinician completes a discharge assessment on 6/1 but doesn't finish her documentation until 6/2, is M0090 on the discharge, is it 6/1 or 6/2?
It is in fact 6/1. The issue is in the language of the guidance that talks about the last day information was collected on this particular patient. And so if I don't put the answer in until the following day, if I have not completed my documentation, it's not allowing it just to be, I didn't get to it today. It really has to be, when was the information collected? So that would stick at 6/1.
Okay. And can you elaborate a little bit on that about the start of care? I have a question regarding the start of care, but let me ask that first, and then we'll go a little bit further into the start of care M90.
Okay.
Second part of this question: if start of care does start of care, if the start of care nurse does start of care on 6/1, patient sees patient on 6/4 and emails the SOC nurse on 6/4 with collaboration suggesting an update to the scoring, but the start of care nurse doesn't return to work to receive that email until 6/7, which is outside the 5-day window. Can she use that collaboration, since it was provided within the 5-day window, to update to 6/4 for the M90?
So that is a very specific situation. I just want to clarify, because you were referring to the PT sent the email, not the patient.
Right.
That
Sorry.
technically collaboration did not occur in that 5-day window. The message was left, but the clinician doing the assessment and who ultimately has their signature on that document did not engage with that information until outside of that window. So others might feel differently, and if you want to chime in the chat box, feel free. But as I prepared for this particular question, for me, it was outside the window. And it's unfortunate because an attempt was made, but I think the bigger issue here is, and some of you have heard me refer to this in other Q&As when we've talked about related topics to this, is that when we're talking about that start of care 5-day window of collaboration, collaboration requires two-way communication between the individuals who saw that patient, who have that information to discuss with each other. So in this case, a message was left and not received. It made me think about those situations where, let's say the nurse does go out and do that start of care on 6/1, PT goes out and sees the patient on 6/4, does an evaluation, submits the evaluation to the EMR, and then the following day, someone in QA reads the PT evaluation and then goes back and tells the nurse that they need to change their answers based on the PT eval. That is not collaboration either, because the PT and the nurse have not actually communicated to cause collaboration. So I've always looked at the review process, and on our outsourcing side, we often get asked, well, do you go back and look at the therapy evaluations as part of the OASIS review? We do, but we don't take them and say, well, based on that, your nurse's answer is wrong. We typically would suggest that there's better discussion between the two so that they land on an answer, but I really can't take someone else's work and use it to correct somebody else's if they haven't actually interacted.
That's pretty clear. Thank you, Cindy. And we have to be careful. Again, most of those M90 questions are being answered with the date of the start of care. There is literally almost no justification for that, because unless you're finishing everything about that assessment and you don't notice any changes in those first 5 days, you need to be careful and put the correct date of the completed OASIS, right, Cindy?
Well, I think some of it is just the mechanics of the questions related to, did you find a clinically significant medication issue? Built into that is the subsequent question of getting two-way communication with the physician within 1 calendar day. At a minimum, if I do hear back from the physician's office the following day, and that allows me to know, okay, we've had the two-way communication and this is what we're going to do about it, then at a minimum, my date assessment completed has already moved to the following day, just with that question alone. So I think we have to make sure that we're not overinflating the time it takes. But to your point, Sherry, CMS has decades worth of assessments that insist that we are able to get everything done
now I can't.
in
I
one
my
shot.
computer down here. No, it's fine. It's just a webinar. It's fine. How are you?
We hopefully we can get those folks muted so that we can get back. Scott, you on that? So, okay.
I'm sorry.
Okay, I'm going to start with a
That
couple more questions on the OASIS, or keep
I
going
can
on
imagine.
that tip.
Yeah. Well,
We're good, Sherry.
Okay, we're good. All right, so M 2020, management of oral medications, still rearing its head, Cindy. If it has been established with skilled visits that with the help of a caregiver, setting up meds and placing it in front of the patient to take, then that will, and then they take it without having any difficulty swallowing, or they take it safely, that this can be considered an answer when answering M 2020. What does CMS mean by in advance for coding 1A? Could this mean 30 days or 30 seconds?
Well, thankfully, when we go to the guidance, we do not see that CMS has put a specific time frame on it. Now, you may say, but I want a time frame. And I go, yes, we always have to be careful what we wish for. Because the minute we push this and say, is there one? And they give us one, now we could say, we don't like it. It's too short, it's too long, it's too this, it's too that. So I want us to think about medication setup along the lines of how setup is structured in the GG items. So if I'm going to use response 5 for a GG item, which is setup or cleanup, our guidance around setup boils down to we have done something before the task or after the task, but the task itself, they're able to complete independently and safely. So in this scenario description, if I am, putting pills in a container and I set that container in front of the patient and I walk away. So I have no concerns whatsoever that they're going to get every single one of those oral medications into their body at this time correctly. All I did was put it in front of you and I left the room. Then I say you have what you need to say this was set up. You were setting them up for this, okay? So it isn't I have to set it up in a pill plan or 30 days in advance. If I'm doing that and that works, that's one option. But the issue of setup is once I put this in front of you, I'm going to go in the other room and watch TV. I'm not going to hover. I'm not going to have to remind you to take this again. I'm not going to sit here and have to put it in your hand and put it in your mouth, all of those things. So I think if we approach it that way, it also helps us make sure we don't over give them credit for the setup. So if I put it in front of you, I've set it up. Okay, it's set up. Oh, wait a second though. Am I still comfortable enough to walk away? Is this mechanism in place for oral medications, creating an error-free environment? Because we know if there's even one medication at this time of the assessment, as we go through all of this, and there's a medication, even just one, that they did not take right dose and or right time, we have an error, and that tells us in the guidance that the only response option we have at that point is response 3. Even if they live alone, even if nobody's physically putting the pills in their body right now, the issue is if I'm any other response than 3, it's not just the mechanism, it's that mechanism is bulletproof. It is working consistently and there are no errors occurring. So that's why we have to look at this from a safety standpoint. And that setup is really, I have put it here, whether it's the pill planner I filled a week ago or the pill cup I put next to you next to the chair, I am walking away from you and trusting you are going to do that correctly and safely without any actual involvement from me.
Okay. Not last Oasis question, I think, Cindy, unless someone submits one. M 2003 and M 2005, any suggestions on how to meet this compliant measure when the physicians don't respond to notification or calls regarding severe drug interactions and do not change any medications? I rarely see the physician change the medications for a severe reaction.
So I think, again, I'm going to go strictly off the question as worded. What jumped out at me was severe interaction. Now, we have to keep in mind that when we're answering item 2001 with respect, are there any, have we done the drug regimen review? We answer yes, there are clinically significant issues if we've identified something related to their medication that rises to the level that the clinician believes the physician needs to be contacted right away. They could be issues of duplicates or interactions. They could be that they haven't got the money to get a medication that they should have. It could be that they've taken too much of something or too little of something. But the litmus test of 2001 remains the same, which is, does the clinician in their clinical judgment believe that the physician needs to be contacted right away? When I see terms of severe interaction, we have to be careful that we're not conjoining this exclusively to the mechanics of a drug regimen review. So they've entered all the medications into the computer, and the computer spits out, this is a severe interaction. This was addressed in a recent Q&A as well about what if it comes out this way and, agency policy is XYZ. Okay, that's one thing. But regardless of what the computer said, is this something that you think needs to be alerted to the physician right away based on your clinical judgment? So there can be issues where things are popping up on a DRR that, especially as I'm not a nurse, I'm a therapist. When I first started using DRRs, I about had heart attack all the time. I'm like, oh my gosh, you're not supposed to take this or that with that. And oh my gosh, it's like turning all these colors. And I would have to be talked off the ledge to say, no, that's a common issue here. The doctor knows this. They referred it for these purposes. What really would blow my mind is they referred it that way to get the interaction. And I'm like, okay, this is it. I'm going to lose it. So we want to be careful before we trigger 2003 or 2005 that we followed the guidance for 2001 and not just automatically said anything that pops up on the DRR means that there's a problem and means that we have to deal with 2003 and 2005 because we need to use those appropriately. And some of you may have heard my previous tirades about I do believe to a certain extent we are underreporting in 2001 because we're just looking at the DRR. So if I run a DRR and it doesn't flag anything, then there's no problem. But I'm looking at a patient who can't afford medication, who doesn't have the resources, who tells me they're not going to take their medication, who's taking their pain pill exactly as they were told by the physician, on the prescription, and their pain is out of control regardless. So I am going to call the doctor about this. That is a clinically significant medication issue. But I think as an industry, 2001 because of the heart of this question, which is when I'm in a situation where I have to try to get to a communication with the physician, I encounter physicians that don't return my calls, that don't acknowledge that I've communicated with them. They don't have to change the medication. It's not a requirement that they have to. So even if I alert the physician, I believe it's clinically significant, I have contact with the physician, and they say, I'm not going to do anything about it anyway, it's a desired effect or blah, blah, whatever the rationale is, there is no requirement that they have to change the medication. It is that you have communicated this and they have communicated back with you to either say, yeah, thank you, do nothing, or let's change this, or let's do that. But it's still their decision to make.
Mhm.
I've argued for a long time now that part of the problem is if I try repeatedly to get a response from the physician and I don't get it in one calendar day, I do have to answer that with no. And I think there are agencies that are putting, yes, they did, when they actually did not, because they don't want to put no, because no feels bad. It feels like we look bad. If we're part of a hospital system and they get wind of that data, they don't like it either because how come this other agency is so successful with this and you're not? And it's very difficult to explain it by going, I think they're fibbing and I'm trying to tell the truth. What we've seen work is with more technology, with more ability for physicians to access our information in a platform, to be able to get information through a system. In many cases, that has improved our situation beyond when it had to be, trying to stalk or call them and track them down and those kinds of things. I think it's really important that we identify if it's specific physicians or specific physician groups and have as much of an educational conversation with them as we can about this. That this is not because I'm not going to call you for every little medication thing under the sun. When we are calling you about this, it is because we believe there is a clinically significant concern. And our goal is to keep your patient safely at home. This is not just a paperwork busy issue. Do I think we will ever reach a situation? And if any of you out there say, this is never a problem, 100% of our physicians respond within one calendar day. I admire you, I envy you, but I think we're always going to have those situations where we don't get the two-way response in time. And I think it's going to be important that we all agree that when we don't meet that expectation, we do honestly report no. Because briefly, Sherry, being part of a discussion with CMS several years ago about this and raising that question about Why are we essentially being penalized with this no? There's no response that allows us to say, I called the doctor and they did not call me back, so it's really not my fault. What they produced was the data that indicated that a very small number of patients, much lower than I expected, are even being put as, yes, there are clinically significant medication issues in 2001. And then of those that are yes, the data is overwhelmingly reporting that, yes, we do get two-way communication within one calendar day. So from CMS's perspective, why would I change a process that isn't broken? So I think part of it, again, it's a complicated issue. I think we really need to have some sit down with individual physicians if this is a chronic problem with them. But I don't think it's realistic to say we're going to get to this utopia where I'm going to get it to 100% that they always get back to me in one day. I wish we could, because this is a patient safety issue. And my pushback to CMS was we're not complaining about the question. We totally get that the physician needs to be notified right away over clinically significant medication issues. We're just trying to tell you that when they do not respond, I take the hit, essentially. And that doesn't seem to be fair.
Okay, I agree. It's not fair, and sometimes you wish that there was that little button you could click that said physician was notified, but they never returned the call, because then that would tell Medicare a lot more information about how difficult it is for agencies to get that information on the fly from providers.
But real quick, Sherry, though, I still think some of it's residual. I mean, I've been around this industry a long time. We used to be able to get away with leaving a message that basically was, if you don't get back to me, that means you agree. And it was convenient and it was easier, but did you really know if they ever got the message? Did someone else intercept the message and not pass it on? I think they were putting in some of these kinds of things, like the face-to-face as well, with some requirement elements we may feel are onerous, but it's really trying to say there has to be that engagement. Again, it's not really fair that, with face-to-face, if it's wrong, the physician doesn't get penalized, we do. But I think it was really an attempt to curb some of that behavior that went to excess, which was, I'll just take a patient when the referral says home care and figure it all for them. Or I have doctors and I just leave a message and say, is it okay if we do this? Just call me back if you have a problem. And they didn't call back, that's agreement. There are risks involved with that.
Okay, another Oasis question popped up in the chat, and I want to remind everyone that if you do have a question come up, please use the chat box, and we'll get to as many of them as we can. In 2020, what about access to the meds and drink? Yes, at some point the meds were put in front of the patient, but if the patient requires at least supervision for walking, how would you answer in 2020 with this info?
So this has been a long-standing attempt to connect mobility absolutely to item 2020 and 2030. The guidance expanded over the years to really try to get the clinician to think about this holistically. So not just does the patient know what they're supposed to take and when are they supposed to take it, but do they have the ability to access it from where it's kept? Can they get it open? Can they get the water? Can they get it inside of their body without making any mistakes? So the guidance was really, and continues to emphasize, look at all of these things that could affect someone's ability to get every dose, right time. Where it kind of comes off the rails sometimes is, well, anybody who needs assistance with mobility has to then be a 3 in 2020. If we're going to start making that kind of direct relationship, we're not the ones who make that relationship. That would be CMS. I would need to see a CMS Q&A, a CMS guidance update that conjoins those in that way. To date, we don't have that. We have look at the patient individually, look at all of those factors. And yes, if the patient lives alone and has to be able to go access their medication and they're at high fall risk, okay, but are they making any med errors? Because if they're not making any medication errors, you can't just go to 3 because they have a high risk for falls. So there's a relationship that we have to explore, but there's nothing from official guidance that says, if they have to be supervised to walk, therefore they're making medication mistakes. They may not be.
Exactly. Okay, so Cindy, we're switching gears a little. Those of you that are on this call are probably aware that the proposed rule is available for review, and it's also available for comment. And there was a part of time this year that we didn't know if they were going to allow us to comment on this final rule. Well, I'm glad that they did, because one of the biggest things that everybody's reading about is the pay cut, is the revenue decrease that CMS is proposing based on some behavioral changes in home health. But the biggest one that probably blew our minds most recently, when it comes to the final rule and it comes to all payer submission and all of the changes that have happened since July 1st, was a question on the recent Q&As for OASIS, Cindy. And my question is really simple. Do all providers have to do the OASIS and submit, including Part B in the home providers?
Now, those of you who went, what is she talking about? This is why, even in the midst of all the July focus on the proposed rule for 26, I think that the July Q&As for OASIS may not have hit the radar as hard as they should have. And for those of you who do track those regularly, you know that leading up to July, there was a whole lot of submission related questions about what about this payer? What about self-pay? What about indigent? What about private insurance? And CMS had a pretty consistent response that it is all payers and it is for skilled services. The exclusions to OASIS under 18, all that, those stayed in place. And it's not applicable if they are not receiving skilled services. And okay, I think some of us were chuckling at that. Well, what about this payer? And going, you know what they're going to say? They're going to say, skilled services, da 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 da. Well, the question out of the box, the first one addressed in the July Q&A, references a patient who is not currently now a home health patient under skilled care, but is receiving therapy in the home under Part B. And the response, for those of you who may have seen it, was yes, they need OASIS as well. Now, I was like, huh? Wait a minute, that's a whole different situation. Because if you're talking about Part B therapy, the ability to provide it in the home has nothing to do with homebound status, has nothing to do with physical impairment. The patient can simply elect to do Part B in the home. If you look at the Part B therapy rules, it right away, and I think it's kind of funny, lists the home sequentially ahead of clinic in terms of where this can be provided. So this is a whole other part of the Medicare benefit, and those limitations of skilled care in the home don't apply. This is not tied to a patient, because if the patient had significant mobility issues enough that they could not safely access outpatient therapy, then I'd be thinking, why are they not still under Medicare Part A home health as a therapy only? But if they've reached a level where they're no longer homebound, they don't need nursing, because you're not going to get that under B, and all of a sudden they want to go to outpatient, they need to go to outpatient, but it's more convenient to have them come and see grandma. So we elected to have it in the home. Mind blown to say you need OASIS. Now, there was some question then, well, maybe this is just for home health agencies that provide B. So we reached out to some people we know that own a rather large system of outpatient in the home, Part B in the home, and they contract to home health agencies. And their response was, well, it doesn't apply to us. But if you read the Q&A, if you're contracted to the agency, then isn't this still provided by? So Mary Carr, from what used to be the National Association of Home Care and is now the Alliance in charge of home health regulatory things, has already pushed back to CMS to basically say, time out. What is this, basically?
Yeah.
Because I don't think anybody other than maybe whoever submitted the question was thinking along these lines. And there's been quite a bit of, oh my gosh, if this is true, and I have a Part B line of business in my home health agency, I didn't collect OASIS on them in preparation for July 1. I haven't been submitting any of it for July, and now we're almost at the end. How do I go back? Do I have to retrofit it? I can't go back and do it, like pretend I did it. Do I have to do it now? What do I do with it? I would say before you hyperventilate, let's wait and see what information can be gleaned from trying to get clarification. Because this really doesn't make sense. From my personal opinion on this, Sherry, and I've already told you this, but I'm going to share it with the group, is if the ultimate goal of moving to all payers was ultimately to be able to look at any differences in terms of outcomes, is there differences in outcomes? Because they've been able to look a little bit between Medicare Advantage and traditional Medicare, but now being able to pull in private pay, pull in private insurance, and be able to look at outcomes, those outcome measures, particularly the functional ones as a therapist, don't make any sense on someone whose abilities have reached the level to be in outpatient therapy.
100%.
Those tasks are talking about bathing and dressing and yeah, they're probably doing those things already. And I'm not quite sure what information from an outcomes. Remember, collecting OASIS on these other payers is not about payment. So what we would collect on OASIS for a Part B therapy case would not have anything to do with payment. That's on a whole different billing structure, CPT codes. None of what we know home health to be is how you bill outpatient. So this does not seem to make sense. So we will keep everybody posted when we hear something about this. Fingers crossed they realize that came out wrong potentially. But yeah, it's something that if you want to send a question into and say, excuse me, what does this mean? I was just shocked to see it. I hadn't anticipated that they'd try to carry it into Part B therapy.
And make sure you submit that question to the OASIS Q&A desk, because that's who put this out for the July OASIS Q&As. And I got a particular kick out of, we know it's not the same fiscal intermediary, so reach out to your Part B intermediary. That ought to be fun for that Part B intermediary.
Oh, to be a fly on a wall.
Yes.
When the Part B gets asked, like, what do you want to do with the OASIS? And they're going to be like, nothing. What are you talking about? So
where did that come from? But
I don't know.
It's in black and white, and it needs to be paid attention to and adhered to with like Cindy said, keep an eye on it, that they have a retraction. Gosh, we hope so, because this could be a real messed up situation. See, I'm being very PG today, Cindy. Okay. But I do want to take our focus back somewhat to the proposed rule, because it is out and it does contain interesting things. And we as an industry have not ever really been ones who comment in droves. In fact, I remember when we put out a blog, Cindy, way back when, where it was talking about a horse convention that was going over their bylaws, and they had something like 4,000 members of this horse association, and they gleaned about 3,200 comments on the changes of their rule book. And I was like, wow, that's quite a turnout. Typically in home health, we have about over 11,000 agencies, which if you calculate that, you have to have at least a DON administrator. So that's one employee. So think about 11,000 employees minimum for that many agencies, 11,000 plus. We typically come in the hundreds, in the low hundreds, typically between 1 to 200 comments. And many of those comments are from professional organizations, state associations, AOTA, the APTA, the ASHA, the therapy associations, they get involved. And we don't see nearly as many as we should from even just the administrative team at each of the agencies. Cindy, can you talk a little bit about what that kind of apathy says to CMS?
Well, much like when we touched on items 2003 and 2005 about communication with the physician, they do take our lack of comment as agreement with what they want to change. And it's always just blown my mind, as Sherry said, with 11,000 agencies to get 175 comments. And not only do we see consistent participation from associations, we also see that many of these associations generate, a template for a response. And then a whole bunch of those comments are basically cut and paste of a template. And the Alliance has recently hired Hillary Leffler, who used to be high up in CMS, was over the home health part, and I had interactions with her professionally over the years. But she has left CMS a while ago and has now joined the Alliance. And in a recent meeting, she was saying that the templated, essentially cut and paste letters don't really have that impact.
Mhm.
That when we're talking about what is projected to be the biggest cut, the biggest single payment cut to home health ever, her recommendation was that it's going to take a lot of comments and it's going to take patient examples
Mhm.
of what this means to real patients. Obviously, not divulging HIPAA stuff and getting us all in trouble, but scenarios, examples, patients writing letters, families writing comments. It's going to take a reality check of what it means to cut that kind of money out of Medicare home health. Because if it's general comments, if it's, we think your math is faulty again, we think, well, the Medicare cost reports are errors, so it's not fair for you to do this. The industry's tried that multiple times before, and now we still end up in the current situation we're in. And so it seems we should be able to get 11,000 comments at one per agency. But I think there's been a lot of, well, the Alliance is going to comment and AOTA is going to comment and this one's going to comment. Does it really matter? It does. And the more boots on the ground, real, what happens from that kind of a payment cut is really believed to be the only hope we have
Mhm.
in trying to get them to back off on this going into 26.
And I think that we need to be realistic in our comments as well. We need to literally show and give those patient examples or that patient population example. What would happen to those folks if they had to have their services taken away? And I think that if you use the example of the professional organizations, they write great templates. They will give you places to look in the document and give you the highlights and the high points of the document that they feel are the most egregious. What you need to do is comment about what is it about that item that would make it egregious for you to practice. And I say this about, you need to tell your patients about it. You need to tell your clinicians about it. Anybody that loves this benefit needs to have their voice heard. The example I like to use, Cindy, and this is probably going to make some folks cringe. Does anybody enjoy the NOA process, the notice of admission process? Does anybody know how that came to be? And Cindy, you do. We've talked about it ad nauseum. During the time that was in the proposed rule, the national associations for outpatient providers and physical therapy had their act together. And their act together was to get as many people as possible to say that the notice of admission was necessary for their practice so that they would know when they were on home health so that they could bill appropriately for outpatient and get paid. Now, there was always a system set up that they could do that. Outpatient clinics have access to the common working file just like we do in home health, just like they do in the hospital, just like they do in skilled nursing, IRF, everywhere else. But they didn't want to do that process. So they got their act together, and literally every other comment that year, we had over 300 comments that year, and more than half of them were in favor of the NOA. Cindy, do you have anything else to add to that?
Well, I think that also speaks to the fact that really anybody can comment
Yep.
during these open comment periods, because it was just reading all of these rousing endorsements for implementing the NOA was like, who are these people?
Yeah.
This is weird. This isn't even, but their mobilizing effort made it look like the NOA was a great idea. And it simply came down to this, that we know that when a patient is under a Medicare Part A home health episode, they cannot concurrently get Part B outpatient therapy. They can't, because therapy is part of consolidated billing. It's part of the home health suite of services. You can't go get therapy as an outpatient at the same time you're actively in home health. We know this. And we know that when we send somebody to outpatient, when we're done, that we discharge them and then they can bill B because this, well, part of the problem was home health, at least the argument on the outpatient side, was home health was taking a long time to get these discharges processed and get themselves out of the common working file. So let's say I discharge my patient on Friday and their outpatient appointment is on Monday. Well, likely I have not completed all my documentation steps for a discharge and they're not pulled out of the common working file yet. And a very anxious outpatient biller drops that first bill on Wednesday and it gets kicked out and denied because they're under home health. Very often that got called a denial, but all it was, I'm not going to pay you right now.
Yeah, it was just a
All
delay.
all they had to do was resubmit it. And once the home health discharge had processed, they got their money. So some of you may be saying way too much talk about outpatient therapy today. It's for context because with these changes, what they're proposing in this rule, if it makes you mad, you got to channel that rage into the comment period. And I'm
Yes.
not saying write angrygrams, but I think they need to understand what this means in terms of patients, not just in terms of dollars and cents. But I think the other piece, and some of you may have seen the blog post Sherry did recently, posted recently about you expect us to cure dementia. I think there's so much focus on the payment implications as I totally understand and rightfully so, but that is not the only thing in the proposed rule. What I'm annoyed about is one of the things that's not, because 1 year ago in the proposed rule for 2025, they asked for requests for more information from the industry about finally removing the requirement that if nursing is involved in the care, nursing has to do the admission. We know we field tested that works perfectly fine during the pandemic. We did our own demonstration project that if it's nursing and therapy together and a therapist did the admit, the world did not end. We did not have a bunch of people running back to the hospital. We didn't have a disaster in the home health space because of that. And so there was a lot of comments made about, yes, please do this. The final rule for 2025 completely skipped it. Like, forgot they asked. And then in this proposed rule, again, non-existent. So I've been talking to some folks that are already gearing up to say, I'm commenting about that. I know that it's not in here, but I feel strongly that they should just finally do this. And so I'm going to go back and talk about, you had an RFI a year ago. We told you this is what needed to happen. I'm just putting it in here so my voice is heard because they have to keep these comments.
That's right.
They have to have them somewhere. So we can do things like that. But there's other parts in here that the reason I wrote that blog about dementia is the change that they want to make in the quality reporting program and wanting to get information about a metric around cognition, cognitive functioning. And I think we can all agree that cognitive functioning, when patients have those issues, it can turn a home health plan of care upside down.
Yes.
It can change how I'm going to teach, who's going to see them, how often we can see them, how long we may have them on service. It can cause all kinds of things. So I don't think anybody would make a comment, we don't care about patients with dementia. You know, cognitive functioning is unnecessary. We don't have a problem with that in home care, and so don't do it. But I think that reading through there and realizing that no other post-acute setting, SNFs, IRFs, has any sort of attempt to create a measure as to whether or not we can improve cognitive functioning. It's like, do you not understand our patient population at all?
Yeah.
I mean, how am I going to reverse their cognitive issue? Now, some folks I think make good points that if it's a very specific situation where maybe their problems with cognitive functioning are related to medications, and by going out there and troubleshooting that and getting them on the right balance of medications, yes, they could demonstrate an improvement in cognitive functioning. Those usually aren't the ones that causes the most GERD. It's the dementia folks. It's the, even, looking at the OASIS item 1700, the forgetful folks. They're forgetting what I tell them. They're forgetting when I'm supposed to come. They forget to the point they don't open the door. Those things have those impacts. How am I going to fix that?
Mm-hmm.
And again, I think if we are hypervigilant and just beat the bushes and Sherry's dream comes true and we get 11,000 comments about the payment cut, and nothing is said about anything else they suggested, they're going to do everything else. So you can comment on multiple things in one comment, or you can send more than one comment. If you
Yes.
want to split it apart and say, here's how I feel about payment, here's how I feel about your quality thing, here's how I feel about this other. And I know, I've always been annoyed that they dropped this thing in July. You started off, Sherry, by talking about the dog days of summer. People want to be on vacation. They want to get that last minute trip in before back to school. They want to have time and enjoy it. And we get our wonderful, happy summer rule drop. And it comes at a time where it's not beach reading. Nobody wants to take that thing with them on vacation and read through it. So it can become very easy to say, oh, other people do that. I'll just go to that webinar. They'll give me the summary. That's all I need. I challenge us. Some of you may read it start to finish, and I admire that. At least look at how it's organized and what the sections are. And if there's a section that jumps out to you, read it. Because they're required to explain themselves to the industry, not to associations, not to quote experts. This is directed to you and your agency and to your staff. So if there's things on there that don't work, or if there's things that you do, I don't want to make this whole thing, we're just going to make comments when we're mad. If there's things in there, like them finally fixing the disconnect with face-to-face between the guidance and the actual laws, you can say, yeah, that's great. Thank you for finally doing that. And it's not so confusing. It's okay. And I think sometimes we got to throw them a bone that says, yeah, that was a good thing you did. Just like we did when they fixed that ridiculous previous version of the therapy reassessments where we had 13, 19 all added together. When they changed that to just minimally every 30, yay. But that was a lot of work too with respect to the comment period. So engaging in those webinars is great. Reading those articles is great. But if there's a piece of that where you're like, that really just motivates me, or I think would motivate my staff, just cutting that part out and say, let's read this. So what do you think about that? Do you think that's a good idea? Then you can tell them. You think it's a bad idea? I typically just say, don't say it's a bad idea. If you've got an alternative or a suggestion, you can put that in there too.
And we will be sending out more information as we go along, but just to give you kind of an idea of why we're pushing this so hard today and taking up this time to do it, is that we're on day 24 and we have a resounding 73 comments so far. So we only have 36 days left to comment. So use this link, and I will be sending these handouts out. So use this link to access the final rule, and above the final rule, you'll see send in a comment. And it also allows you to read some of the comments that have been submitted as well. So doing that little bit of activity and informing your staff of why this is so important, and particularly to the 1,000 under census folks. Y'all aren't the ones that got us here. And I say that, it's a generalization, I'll give you that, but the ones that got us here were the ones that said PDGM cut our payments, so we cut our services. And CMS is looking at that very distinctly, and they're adding the fuel to the fire for me is that they have actually proposed a raise to all of their settings except for home health, based on our behavioral changes. And so we have to kind of be realistic how we got here, but they need a good picture of what's going on in the non-PE funded or the non-hedge fund funded agencies that didn't try to cut services down to bare minimum and still be paid at the PDGM rate. So something to think about it as you're doing your comment, that you need to give them a good picture of what's happening, boots on the ground on those medium and small agencies. Really, really do. Your comment means as much as it does coming from the other agencies. So definitely get involved. So this link will be sent out to you. The next link we always add is the fact that we do compliance. Cindy and I have started this adventure, golly, 12 years ago now, with the opportunity to make agencies better. We're a different kind of partner, and I want you to know that when we partner with you, one of our main functions beyond accuracy, Cindy, accuracy is the pillow we put our head on at night, is to make your agency better, to help your agency fish versus giving you a fish that's just going to spoil when we leave. Did you have any other comments on that, Cindy?
No, I just think, again, we do have a couple questions we can take if we still have a few minutes, but we just feel very passionate about this industry and this space. And we're going to comment, but if that only takes it to 76,
Yeah.
be in big trouble.
Exactly, exactly. So we need to get involved for sure, at a very basic level. And like I said, if you have some outspoken patients, give them the information, give them the link or the address to send a letter. All of those things make a difference. And I think the patient directed issues in the scenarios, they hold a lot of weight when it comes to them making those changes in the rules. And so really going in on what a day looks like in the life of an agency that's not pulling a 25% profit, because that's what they really believe in their hearts. CMS and MedPAC and all the ones that gather this data, they truly believe that we are all making a 25% profit, and that's too high for Medicare. Cindy, is that pretty succinct where they're coming
Yeah.
from?
Well, that's a whole other can of worms about cost report accuracy and where they got that data from. But I think we can bemoan how we got here. The issue is we are here. And if this goes through, losing over 6% is a huge hit. And it's going to affect agencies differently depending on size. So I think we've made our point on that, Sherry.
So I want to give everybody the opportunity, if you don't know already, that we have a Club Oasis, and so some of the Oasis questions that we gather throughout days and times are going to be answered. Our next live Oasis discussion regarding the July 2024 or 2025. Good God, what year is it? The July 2025 Q&As is on August 5th, right, Cindy?
Yep, August 5th at 1 p.m. Eastern.
And if you guys want to join us next year or the next time we do this session, it's going to be September 25th from 1 to 2 p.m. And go ahead and when we send out the link of this and the recording and in the handouts, we'll also send you the link to go ahead and register. Do that as soon as you can so that we know how many to count on and how much infrastructure we have to put into place for everyone. And I'm going to open it up for anybody who may have a question that they want to pop into chat real quick as we go to end up. Cindy, did you have anything top of mind that was that you wanted to share before we go?
Well, we did have a question, and I just want to kind of address it globally because it keeps coming up, is the issue of the activity non-attempted codes in the GG items. And some of you may go, ugh, don't get her wound up. We don't have that much time left. Yes, there's still discussion about if you should avoid them at all costs. They have the plague. Never use them. Always put a different code other than the activity not attempted, forbidding use of those. Again, we want to make sure we're following the official guidance. The issue is that an activity not attempted code should not be our knee-jerk response selection. It should not be the easy way out to just go ahead and say, I'm going to put one of those. They really should be, much like the dash in OASIS, the last resort. So even in questions when we can use a dash, CMS repeatedly says, we expect use of this to be rare. So I would say when it comes to the ANA codes, we expect the use of this to only be the last resort. We do not expect it to be non-existent, because my fear remains that they have years worth of data stockpiled on the GG items because they're not new and they see what they've seen in terms of the prevalence of the various ANA codes. And now that we know that they are affecting reimbursement, if we suddenly drop drastically, this reminds me of some of that data in the proposed rule that they're using to support the pay cut by saying we built PDGM on this number of visits, your visits declined, yes, then the pandemic happened, and your nursing visits have stabilized or rebounded, and your therapy visits are still way lower than we thought, therefore you need a pay cut. I'm concerned here that if it becomes, well, you were using the ANA codes, now you suddenly don't use them ever. That also seems to reinforce by extension this concept of a behavioral adjustment, that we pay more attention based on whether or not affects reimbursement. So when I saw that pop up, a different version of it again, I just wanted to remind folks, nobody should be never ever touch them unless CMS tells us don't do that. You want to make sure it's always in the, if we've vetted every other option, we've looked at the guidance, we've talked to the caregiver, we've looked at all of this, and realistically, this is the only answer left, then that is what we need to be reporting.
Cindy, I don't think I see any other questions in the chat, and I just want to thank everybody for their attendance and patience today. And Cindy, did you have any final thoughts before we go?
Well, I know that there's folks that listen to the recorded version because they're busy and can't get to the live one. So if you think of a question or you have, a comment about the comment period or need some assistance with that, please feel free to reach out to us. Just because you weren't here in person doesn't mean you don't get to ask your question. If you have a specific question outside of the rule thing, and we want to just kind of punt that over to the September session, we're happy to do so. And to any and all, if you have a question, and it doesn't have to be just an OASIS question, it can be a home health related question of any kind. Just know that if you give us a question that we do not know the answer to, we will not fake one. We will tell you when we don't know, and we'll try to research and get information from reputable sources to address those as well. So I love the OASIS questions here, but they don't all have to be. So if anything pops in your head and you want to just shoot the question over on our website, fill out one of those forms and we'll file it away for our discussion in September, because we want this to be useful to you. Sometimes I worry it sounds like Sherry pokes the bear and then I get all ranty. But I really want this to be useful to you as you participate in each one of these sessions. And I know your time is valuable, and we very much appreciate you carving out some of your time to be with us today.
Thank you so much, and be safe out there.